Good afternoon and welcome to the 2022 Clinical Research Symposium. My name is Rafael Cuomo and I will be moderating today's events. On behalf of the Clinical Research Program at UC San Diego, thank you for coming. 60 years ago, a child diagnosed with leukemia would have been expected to live no more than 6 months, and now childhood leukemia has a cure rate exceeding 90%. 30 years ago, an HIV diagnosis was considered a death sentence. Today, serious voices are talking about eliminating the disease completely. And of course, let's not forget that just 200 years ago, global life expectancy was only 28 years, now over 70 years. These advancements have been made in no small part due to research like what you will see and hear today. The first session of today's proceedings will showcase 4 oral presentations carefully selected by the faculty directors of the Clinical Research Graduate Seminars. For this first session, we are fortunate to have an esteemed panel of judges to evaluate today's presenters. Our judges are Ravi Mehta, nephrologist and emeritus professor of School of Medicine, Jennifer Graves, neurologist and associate professor, School of Medicine, Florin Vida, biostatistician and professor, School of Public Health, and Sheldon Morris, primary care practitioner and professor, School of Medicine. They will bestow 2 awards based upon quality of research content and quality of presentation delivery. Presenters have been instructed to keep their talks within 20 minutes, after which we will have about 10 minutes for questions from the judges. Please note that our 4 presenters have also made posters, and they will be available in the poster hall during the next session. Without further ado, I invite our first presenter, Harpreet Bhatia, to come up to the stage.
All right, good afternoon. My name is Harpreet Bhatia. I'm a fellow in cardiology at UCSD and a T32 fellow in the integrated cardiovascular epidemiology program at UCSD. And I'm happy today to be able to present my project involving aspirin therapy for primary prevention of cardiovascular events in people with elevated lipoprotein A. So to start with a little bit of background, lipoprotein A is a lipid-carrying particle, a particle that carries cholesterol in the blood. It's similar to LDL, which people know as bad cholesterol, and it has an additional component to it called apolipoprotein A, which is where it gets its name. It's a genetically determined particle, so levels can be predicted based on genetics up to 90%, and it's present at elevated levels in an estimated 30 to 35% of the global population. So something that impacts a large amount of people. It's not routinely screened for in a lot of clinical settings, so it's not always known about. It's an under-recognized risk factor. However, it's independently associated with atherosclerosis and cardiovascular events through a number of different mechanisms. And this has been borne out in multiple different studies, from clinical studies, meta-analyses, Mendelian randomization studies, even studies of people on statin therapy or on PCSK9 inhibitors where they achieve low LDL cholesterols still have the associated risk with lipoprotein A. So statins and the currently available therapies that we think of in cardiovascular prevention are not effective in preventing disease in this population. And there is no approved medical therapy specifically for this population. The only treatment that's really FDA approved to lower levels as of now is apheresis. And there are ongoing clinical trials of targeted therapies that lower Lp(a) levels, but this is something that's just happening right now. Phase 3 trials are being done in secondary prevention, so for people who've already had cardiovascular events. And we're probably several years away from any kind of primary prevention trial. So to talk a little bit about aspirin therapy as sort of a preventive therapy, aspirin is well established for secondary prevention for atherosclerotic cardiovascular disease, or ASCVD. And in a prior meta-analysis that's often quoted, it results in up to a 25% reduction in yearly risk of a composite outcome of serious vascular events. However, primary prevention is less well established, and this has become progressively more controversial, as people may have seen in new guidelines and in the lay media. The reasons for this are probably multiple, including the fact that in a primary prevention setting, people tend to have lower event rates. Aspirin does have a low risk of bleeding, but it is an increased risk of bleeding compared to not having aspirin. So it's more difficult to balance that risk of bleeding when you have lower event rates. This has led, as I mentioned, to progressively narrower guideline recommendations, including the U.S. Preventive Services Task Force draft recommendation, which was released last year, which really started to cut down the indication for aspirin in primary prevention. One of the questions kind of related between aspirin and lipoprotein A is there a specific subgroup that benefits? We know aspirin benefits people in secondary prevention, but not necessarily in primary prevention when we're looking kind of at big populations. But there may be a group that's high enough risk that sort of equates to a secondary prevention or coronary disease equivalent that they do benefit. This is some data from that meta-analysis in 2009, and this took primary prevention trials up to that time, and basically shows that there is a benefit to aspirin, the 12% relative risk reduction in any serious vascular event when you kind of take all the primary prevention trials together. When you look into the data more, you can see that there is, again, in the primary prevention trials, there's a benefit in major coronary events, benefit in serious vascular events, but this is offset by major bleeding risk, up to a 50% increased risk of bleeding in the primary prevention setting. And when you look kind of at relative risk and hazard ratios, you see similar things in the secondary prevention setting. However, you really see the difference when you look at the yearly absolute risk difference. So for example, for any serious vascular event, there's a 1.5% absolute risk reduction per year in the secondary prevention setting, compared with a 0.07% absolute risk reduction in the primary prevention setting. So the big difference, I think, has to do with the baseline risk, and the real difference is in the underlying population. Then in that trial, that meta-analysis was published in 2009. As many people may know, in 2018, there were 3 large primary prevention trials comparing low-dose aspirin therapy. All of them were 100 milligrams daily of aspirin, comparing that to placebo in different populations. So the Ascend trial was in diabetics without any history of cardiovascular disease. The Aspirin trial was in healthy elderly patients or patients over 70 years of age. They lowered that to 65 in the US to try to recruit more Hispanic and Black Americans. And in the Arrive trial, it was people who were at moderate estimated risk of a cardiovascular event, which would be an estimated 10-year risk of 10 to 20% risk of events. So these are all people all populations felt to be at least moderate to high risk of cardiovascular events, and people who may benefit from aspirin therapy. So in the Ascend trial, this was the only one to show a statistically significant benefit to aspirin, with a reduction in their primary composite cardiovascular outcome of 1.1%, with a relative risk reduction kind of similar to the meta-analysis that was shown previously of 12%. However, there's a 1% increase in bleeding and a 29% relative risk in major bleeding. So depending on the seriousness of the event prevented and the seriousness of the bleeding event, they seem to offset each other depending on which is more severe. In the Aspirin trial, there was actually no difference in the primary composite outcome in elderly patients assigned to aspirin therapy. And similarly, in the Arrive trial, there was no difference in the primary composite outcome. One thing to know in the Arrive trial is if you look at those absolute event rates, they're less than 5% at about a 7-year follow-up. And their predicted event rate was 10 to 20% at a 10-year risk. So one of the issues with these trials is they tended to be underpowered. They recruited people who were at lower risk than they expected. And I think a lot of that has to do with the advancements in other preventive therapies within cardiology. So the meta-analysis I showed previously included studies back to the 80s, where statin therapy wasn't widely prescribed. Antihypertensive therapy wasn't as aggressive as it is today. Treatment for diabetes were less broad and less aggressive. So I think background therapy has changed significantly, and as a result, they ended up probably recruiting a lower risk population than they expected.
Could I ask a question?
Sure.
How many patients each of these trials?
So each, a rough estimate between 10 to 15,000 patients each, so large trials, yeah. So this led to changes in guideline recommendations. So the U.S. Preventive Services Task Force, which kind of drives insurance reimbursement for preventive therapies. So their word makes a big difference in kind of real world clinical practice. They, in 2016, gave actually a fairly broad recommendation for aspirin at that time. So in adults who were 50 to 59 with an estimated risk of cardiovascular events at 10 years of over 10%, they gave a recommendation to initiate low dose of aspirin with a grade B recommendation. And for adults who were 60 to 69, they said basically it's reasonable to initiate aspirin in that group as well, but it could be individualized to the patient. Then they released in 2021 this draft recommendation statement, which is still a draft recommendation, but kind of follows along with other cardiovascular society guidelines like the ACC-AHA primary prevention guidelines, which are moving in the same direction. And they recommend against aspirin in people who are over 60, anyone who's at increased risk of bleeding as well. And then in adults who are 40 to 59 with over a 10% risk at 10 years, they said it should be an individualized decision to initiate aspirin, but they say the net benefit of aspirin use in this group is likely small. So they really kind of downgraded the strength of their recommendation based on those 2018 trials. So again, the question is, does anyone benefit from aspirin for primary prevention? Pathophysiologically, I think, and there's biologic plausibility that someone benefits from aspirin if their risk is high enough, but it's been harder to show kind of in large populations. So people with elevated Lp(a) are at increased risk of atherosclerotic cardiovascular disease events. Current medical therapies are not effective, so statins and other therapies such as PCSK9 inhibitors and niacin, which have historically been used in these patients, don't reduce the risk. The risk still remains. And there's more room for improvement potentially than someone who has elevated risk from another reason that can be treated with other preventive therapies. Additionally, there's a biological mechanism which may play a role as well. So Lp(a) plays a role in thrombosis and fibrinolysis. And there's evidence also for both pro and anti-platelet effects. So it's not quite clear what the net effect of Lp(a) is on platelets, but there's clearly a role in binding to platelets. So elevated Lp(a) may be associated with increased benefit from aspirin, just based on the fact that it's involved, in these systems. Additionally, because Lp(a) has been shown to impair fibrinolysis, it may be associated with a reduced bleeding risk. So the risk-benefit ratio may tilt more in favor of benefit in the setting of high Lp(a). Really, one prior study addressed this question in sort of a similar way. It was a secondary analysis of the Women's Health Study, and this was published in 2009. And the Women's Health Study was a randomized trial of aspirin. It was 100 milligrams every other day versus placebo. And this was in healthy women who were over 45, had no prior cardiovascular disease, and had long follow-up, 10-year follow-up, which is longer than a lot of primary prevention trials are today. And they did actually a genetic analysis. Again, Lp(a) is very genetically mediated. So they genotyped 25,000 healthy Caucasian participants for a single nucleotide polymorphism associated with high Lp(a) levels. They ended up with about 486 people who were carriers of that single nucleotide polymorphism, so a fraction of the initial population, who were assigned to aspirin, and a little more than 400 who were assigned to placebo. This is showing essentially that those who were carriers in the placebo arm had significantly elevated cardiovascular risk. So as expected, but they kind of established that they had over a twofold increased risk of cardiovascular events in the placebo arm. And then this is showing that those who were heterozygous carriers of the allele and then those who are homozygous have kind of an increase in actual plasma lipoprotein A levels. So showing that the genetic risk correlates with the actual plasma levels, which is what we actually use clinically more.
I have a couple questions. So why is there such an imbalance between the placebo and aspirin arm in terms of sample size? Do you know?
I don't know. Yeah, that's a good question. I mean, it wasn't, I think it's just unfortunately a random effect, but.
Well, it can't be, but the second question is, you said that about 30% of people will have elevated LPA.
Yeah.
And based on this genotyping, they found 100,000 out of
Right.
100,000. So
Yeah. So this is, so Lp(a), it's genetically mediated. There's at least 40 plus single nucleotide polymorphisms that we know are related to Lp(a) levels. And so this is just one of them. So this has been shown to be elevated or present in about 3.5% of Caucasians. So it just explains a fraction of the total kind of genetic picture, yeah.
Since there are 30, 40 alleles, can you make a risk score?
So there is a risk score that was developed a couple years ago and has been shown to be predictive of events. It still doesn't, in my opinion, outperform having a plasma level, because a level kind of accumulates all genetic risks that an individual person may have, as well as non-genetic risk factors. As far as we know, there aren't a lot of modifiable aspects that affect Lp(a) levels, but there may be things we don't know about. And so the Lp(a) level is really the best way to capture it. But the genetic risk score that's kind of become the standard one that's used is 43 variants, and it explains 60% of the variation in plasma levels. One of the flaws with it is it's developed only in Caucasians, so it only explains variation in Caucasians. And it doesn't perform well at high levels. It's good at predicting kind of lower or medium levels of Lp(a), but at high levels it doesn't do a good job, which is one of the populations we're most interested in, and the risk increases with the level. And then this is a little bit difficult to see, but this is their key figure. Essentially, in the composite outcome, myocardial infarction, ischemic stroke, or cardiovascular death, you can see one curve separates from all the others, and those are people who are carriers of the SNP who are assigned to placebo. And then those who are carriers who are assigned to aspirin looks very similar to those who are placebo or non-carriers assigned to aspirin or placebo. So suggesting that there is, a benefit here. This is, again, a small fraction of the total picture and the total population, but hypothesis generating. So our hypothesis was that low-dose aspirin would reduce the incidence of coronary heart disease events, which is defined as a combination of coronary heart disease death, MI or resuscitated cardiac arrest, and cardiovascular disease events, which is a broader endpoint, incorporating the CHD events plus stroke, fatal and non-fatal stroke, among people with elevated Lp(a). And we used a level of 50, which is sort of the guideline recommended level cut point in people without baseline cardiovascular disease. Our data collection was performed using the multi-ethnic study of atherosclerosis, or MESA. It's a prospective study of 6,800 individuals free of known baseline cardiovascular disease. Of those, almost everyone had a baseline Lp(a) level. 6,700 participants did. This occurred at 6 centers across the US. Recruitment began in the year 2000 to 2002, and we now have adjudication of events up to 2018, so up to an 18-year follow-up. It's a really richly characterized database with a lot of different covariates that describe patients very well, and with extensive adjudication of events. One downside to this is there's a lack of bleeding outcomes. So we don't have bleeding outcomes to be able to compare that to cardiovascular events. For the analysis, we divided a cohort by Lp(a) level. So we used that cutoff of 50 milligrams per deciliter. Baseline characteristics were compared using chi-square testing for categorical variables, t-tests or ANOVA for continuous variables, for depending on how many groups were involved. And then Manwin EU testing and Kruskal-Wallis testing was used for skewed variables. The cohort was matched based on an aspirin propensity score. So one of the issues with doing a study like this in an observational setting is the residual confounding and confounding by indication. So we aimed to try to match aspirin users and non-users as well as we could, using a propensity score based on face validity. So things that we thought in 2000 may have prompted a physician to put someone on aspirin. So those are age, their sex, race, ethnicity, diabetes, hypertension, smoking, HDL, LDL, and total cholesterol. And then we did a time to event analysis using Cox proportional hazards models, with the primary predictor being aspirin use, the outcomes being those CAVD and CHD events. And then covariates were what we consider to be sort of the standard set of ASCVD risk factors, which is age, sex, race, ethnicity, cholesterol, HDL, systolic blood pressure, diabetes, smoking, and whether they're on hypertension treatment, as well as BMI and family history of cardiovascular disease, which would be in a first-degree relative history of MI or stroke. And we also did some stratified analyses, which I won't show today. So we ended up with a final cohort of 6,600 people after excluding those who were missing Lp(a) data, 42 who were missing aspirin data, and 26 who never had follow-up for events. This is an overview of the demographics, and for the sake of time, I won't go into this in too much depth. There does tend to be increased burden of risk factors in those who had an Lp(a) over 50. So higher BMI, increased prevalence of hypertension, diabetes, things like that. There's also, as you can see, a clear racial ethnic component. So for example, the Lp(a) group less than 50, what we consider a normal level, is predominantly white or Caucasian, and 41%. And if you look at those over 50, it's predominantly Black or African American. And we know from other epidemiologic data that the highest levels tend to be in people, Black or African American individuals, and then South Asian individuals tend to have the next highest. The other main point is CHD events towards the bottom there. There were 386 events in 5,300 people with an Lp(a) less than 50, and there were 119 events in 1,300 people with an Lp(a) over 50. That was significantly different. And then this is showing Cox proportional hazards models with sort of sequential models with increased multivariable adjustment, stratified by the baseline Lp(a) level, looking at the association between aspirin and coronary heart disease and cardiovascular disease events. And at least, looking at this is in the whole cohort. This is not in the propensity match cohort. In those who have Lp(a) over 50, they tend to have higher hazard ratios associated with aspirin. Even in the less adjusted models, there's a hazard ratio over 1 associated with aspirin use. And none of these are statistically significant, but this kind of suggested to us, and when we look at unadjusted data as well, you see that aspirin is associated with increased risk of events. Pathophysiologically and based on mechanisms, we know that that's less likely, and it's more likely that aspirin use represents risk, and people who are higher risk are more likely to be put on aspirin. However, it's not always clear, in 2000, why someone was put on aspirin compared to the more narrow recommendation of why they'd be put on aspirin today. So then this is when we did propensity matching, where we matched aspirin users to non-users, and then compared the two groups based on Lp(a) level and looking at the association between aspirin use and events. And you can see in the fully adjusted model for coronary heart disease, that in model 3, which includes all those risk factors that I talked about, in those with Lp(a) over 50, aspirin use is associated with a hazard ratio of 0.54, which is statistically significant for hard CHD events. For hard CVD events, which basically has those same events but adds on stroke, fatal and non-fatal stroke, there's a hazard ratio of 0.68, but it doesn't meet statistical significance. And this also doesn't surprise us. Lp(a) is less strongly associated with stroke than it is with coronary heart disease, so it's not surprising to us that we saw a less pronounced effect in the cardiovascular disease group, in the broader group. I'm going to skip that for the sake of time. So to conclude, in our study, aspirin use was associated with a reduction in coronary heart disease events in participants with an elevated Lp(a) over 50 milligrams per deciliter without baseline cardiovascular disease. Now, obviously, we have to interpret this in the context of its limitations. So it's an observational study. We have limited information on aspirin. So we just know they were on aspirin. We don't know their dosage, their frequency, their compliance. You can't really assess that very well in this kind of study. And we don't always know their indications for aspirin. We try to guess, what things might prompt a physician to put someone on aspirin or not put them on aspirin and put those into our propensity score. But we don't know, really the indication for aspirin at that time. And these are subject to residual confounding by indication, as I mentioned before. So we think of this as hypothesis generating and have kind of a couple of avenues for further steps. The first is to try to get more participants, more events. So we want to pool this with other cohort studies, the Dallas Heart Study and the ERIC study, to try to get just greater numbers of events and see if we can clarify the strength of the effect. The real long-term goal is to do a secondary analysis of randomized clinical trials, and to be able to, I think, answer a question like this, where there is obviously a lot of confounding and a lot of potential issues in why a participant was assigned aspirin or not. Randomization is really necessary to get the best level of evidence to answer this question. So we have plans and agreements with the Aspirin trial and the Ascend trial to send us blood samples. We're going to measure Lp(a) in all of them, and then we're going to analyze, do a similar analysis of Lp(a) levels in the aspirin use compared to placebo. And that's sort of the big long-term goal, and we applied for NIH funding for that as well. And I want to thank my mentors, who I have a lot of, and I have collaborators with other institutions, but particularly I want to thank Dr. Samikas, Dr. Kricke, and Dr. Vida, my mentors here at UCSD. I want to thank the CREST program and thank the Research Symposium for having me today, and in particular thank Dr. Cuomo and Dr. Macedo for all their feedback and guidance along the way in sort of developing this project and presentation. So, thank you.